mentally competent, and it will remain thus.
Thank you. Baroness Finlay.
Thank you. I think it's important to remember that defining terminal illness is extremely difficult. In the bill that Baroness Meacher proposed, an 18-year-old with anorexia would have been eligible. A diabetic who was insulin dependent would have been eligible by refusing their treatment. So,
in that sense, by refusing your treatment, you then have a terminal condition. Is that?
Well, absolutely, and we know that sadly anorexia is a potentially fatal condition even now, even though our NHS investment has improved survival by 22% in recent years, but it's still a potentially fatal illness. I think you also have to remember that diagnostic error is quite common. There have been cases in Canada of people who had euthanasia but actually never had the illness that they were thought to have. 1 in 20 post-mortems show that there's been a diagnostic error in this country. That was evidence from the College of Pathologists. We know that the prognosis is just about impossible. In fact, Ray Tallis, in evidence to the previous select committee in the Lords, described it as a probabilistic art. And the College of GPs said at 6 months is pretty desperately hopeless being able to predict prognosis. In terms of the law itself, I think it would only be a very short time until a challenge was brought in the courts claiming inequality for whatever reason, if you try to put firm boundaries around it. The Canadian experience, I don't think we can ignore. It has split the medical profession. In terms of Oregon, I've understood that only 2% of doctors there actually prescribe and are involved in this. So to say that it's widespread, it is not correct.
Just so I understand that, because the point made before is that in Oregon there's popular support from doctors, but actually you're saying in terms of those actually participating, it's a far smaller group. So is the question over, you might support it, but you wouldn't participate in it?
Yeah, and the BMA survey that was referred to also showed that the highest opposition was amongst those clinicians who deal with these patients, look after these patients all the time, particularly my own specialty of palliative medicine, but also geriatric medicine, clinical oncology, renal medicine. That's where the opposition came. When you ask people, would you be willing to participate in the processes, the numbers go right down. So theoretically, they think, well, that might be okay, but when they think it through, the numbers drop. The BMA also did a study called the End-of-Life, ELPAD, End-of-Life Care and Palliative and Assisted Dying study in depth, which is well worth reading, and it showed that the public group that were in there, as well as the doctors, the more they learnt about it, the more they became cautious about it. I do think we have to remember about the drugs that are actually used. Nowhere in the world have these drugs been approved by any authority for repurposing. People are completely unaware. Last week, 100 clinicians were asked, do you know what drugs are used? This was in Southampton. None of them knew the doses. It is 100 tablets of barbiturate or 150 tablets of a mixture of Valium, amitriptyline, digoxin, and that's an awful lot of tablets to swallow. The other thing with euthanasia, over 2/3 of patients last year in Belgium were given a short-acting anaesthetic agent, but then they also were given curare. That meant every muscle was paralysed. They will have looked as if they're peaceful, but they were dying of asphyxia. People are just unaware of that. And if I can just add one thing, I did ask many years ago